Great. Thank you so much. So now now we are with Sergio. Of course, I'm going to repeat the same announcement again. Sergio Carmona does not need any introduction. He is the head of the Department of Neurotology in Institute of Neuroscience at Buenos Aires. He is the president of FINO and a very well-known clinician and scientist in South America, North America, and through the world. With that, he's going to talk about something that we very commonly see, vestibular paroxysms. And with all that, Sergio, stage is yours.
Thank you. Thank you, everybody. I don't know if it's good afternoon, good morning, or good night. But give me a second. Can you see my screen? Can you see my screen?
Yes.
Yes, we can see, but you will have to put it on PowerPoint mode.
Okay. Well, this
Wonderful.
talk is about vestibular paroxysmia. Let me show a case. This is a 69-year-old man who came to consultation because he has a BPPV. Somebody performed a lot of maneuver, different tests, but the patient has this kind of spontaneous crisis, and I asked him to record it. And a friend in the kitchen, you see a very domestic video, you can see a dog behind, was recorded during a crisis. Look at this. So you can see that the patient has a clear left beat in the nystagmus, lasting less than 1 minute. And he became very dizzy. So we have to consider these possibilities. Why the BPPV in this case is atypical? Because of spontaneous vertigo, because the persistence of the sign, because he has no response to the maneuvers, all. So in my experience, BPPV is a big issue for vestibular paroxysmia. I will explain later on. Well, this is the MRI of this patient with the cross compression over the vestibular nerve. Another option is a dolicho-basilar. This is a beautiful intrasurgical photo of Dr. Pan from Mexico. They were performing a neurectomy because they think that the patient has a Meniere disease, and they found this cross compression. And this is the aspect of the vestibular nerve in some cases due to vestibular compression. Recently, but associated through the Committee for Vestibular Disease published the criteria, were published in January 2017. And vestibular paroxysmia, each point needs to be fulfilled, at least 10 attacks of spontaneous, this is a very important concept, spinning or non-spinning vertigo. Duration, this is another big issue, less than 1 minute. A stereotyped phenomenology in a particular patient. The patient can have some positional vertigo, but always almost in the same position. Respond to the treatment with carbamazepine or carbamazepine, and of course, not better account for any another diagnostic. Probable, at least 5 attacks, duration less than 5 minutes, spontaneous occurrence or provoked by certain head movements, stereotyped phenomenology, and no other reason. What about epidemiology? They are not P series. they are not epidemiology studies, but it's a rare disease, less than 1 in 2,000 people. And regarding the pathophysiology and etiology, remember that is like in neuralgias, a fatty discharge, paroxysmal interaction and transmission between neighboring partially demyelinating axons. Of course, another cause of nerve injuries, tumor, kiss, compression, demyelinization, trauma, and other unidentified causes. What about MRI? MRI is mandatory, but not necessary to do the diagnosis. Because the cross compression is variable, in our series is just 50%, up to 95%, depends what kind of technology you are use, or the studies are dedicated to document the cross compression. But the MRI should also be performed to exclude the presence of tumor, adenoid cyst, megalodolichobacillaris, brainstem plaques in multiple sclerosis, brainstem infarctions, or other brainstem lesions. Regarding differential diagnosis, think in a BPPV atypical presentation. Always you need a spontaneous crisis to talk about vestibular paroxysmia. Meniere disease, of course, the duration of the crisis. Meniere is at least 20 minutes till 14 hours. In the tumor king crisis, which is a variety of Meniere disease presentation, you had falls. In vestibular migraine, remember the Sudir conference, again, the duration is mandatory, and of course, you had different signs or symptoms. In vertebrovascular TIA, transient ischemic attacks, isolated vertigo is rare and is in combination with other signs of the posterior circulation. And the differential diagnosis is really difficult in paroxysmal brainstem attack with vertigo, and in this case, the MRI is mandatory. Other diagnoses like fistula, panic attacks, epilepsy, and episodic ataxia type 2 are difficult to be confused with vestibular paroxysmia. In summary, short attacks of rotational to and from vertigo lasting seconds to minutes. Attacks may be dependent of particular head position, rarely hypoacusia or tinnitus. During an attack, rotatory spontaneous nystagmus. B and G are not useful. Rarely you have caloric projectability or alterations in video head pull test. The mechanism are the neurovascular cross compression, and the most important point is the therapy. Vestibular paroxysmia responds nicely to carbamazepine, oxcarbamazepine. I had better results with carbamazepine, starting with 200 milligrams once a day, and scale till 900 milligrams per day. You don't need to keep the patient on treatment for the rest of his life. You can withdraw the treatment after 5 or 6 months if it works. Okay, thank you very much. Just a brief introduction to this situation, and if you have some question, I'll be glad to answer it.
So I don't see any questions in the question answer session. So I will ask you one question. So a lot of times we don't see any classic nerve twig compression or anything of that sort for vestibular paroxysms. Although when we scan them, we do see very dolichoectatic basilar artery, like really dolichoectatic. It's not necessarily compressing a nerve or not near the angle, but we do see that. Any thoughts and ideas about, is it the artery which is compressing the midbrain brainstem in general, or it is something that is there which is just not visualized under the MRI? Just curious.
Okay, I had a paper about that, and I do think that this kind of compression can cause also attack of vertigo. And it's the same. The response to carbamazepine is very good. We published a paper with a series of patients that only had dolicobasilar compression over the brainstem. So I believe in this, probably the same or a variety of the syndrome. And let me give you a comment about the MRI in normal patients. You can find cross compression in at least 7% of normal patients. So it's, I do think that it's not necessary to have the image. And another important thing is that you don't need to know which side is the problem, because the response to the treatment is the same, right or left. It's not like in Meniere's disease or a BPPV, you need to know very well where is the problem.
And about
May I make a comment?
Please, Jorge.
This was a very nice presentation, Sergio. The pathology of the specimen that you show there shows the indentation by the blood vessel on the nerve and focal atrophy. And one of the clinical markers that we have, I mean, there's several thoughts here. One of the clinical markers for demyelination of the vestibular nerve is nystagmus induced by hyperventilation. Did you try that? Did you try hyperventilation?
Yes, yes. Hyperventilation is always or almost always a sign of compromise of the A nerve, but in my experience is positive in around 50% of the patients. When you have a positive hyperventilation and all the features that I show you, you are pretty sure that the problem is in the A nerve. You're right. But probably to have a positive hyperventilation, you need some kind of embolization or a permanent lesion of the nerve.
Right. And the other thing there is you also have the cochlear nerve and the facial nerve in that area. And they seem to be a spare. I wonder what the vulnerability is of the facial or the vestibular nerve. Right? It has to be the superior branch, right? I guess, because it's horizontal nystagmus.
I had some cases with tinnitus, and I had some cases with facial hemispasms in combination. But
that's very.
Excuse me. No. I think that the condition is rare, and the combination with other cranial nerves is less frequent.
Tinnitus is an interesting correlation, because it all comes down to, like, is vestibular paroxysms more common in general hyperexcitable states of the brain, right? So tinnitus would be a condition where brain is in hyperexcitable state. I would say migraine, enhanced physiological tremor. How many of these patients are more likely to get enhanced physiological tremor with mild hyperventilation or mild anxiety, for example? So these are all interesting questions maybe we can ask for future studies.
I cannot answer this. But it's interesting that I think that these patients had a completely normal exam, apart from some vertigo in the determined position or the history of positive spontaneous crisis of vertigo. Apart from
There
that,
is one question that came just now. Are
Okay,
there
sure.
changes in ABR tests that can suggest a third nerve, eighth nerve compression?
Yes, yes. We got experience with, we always indicate an ABR, not constantly, but it helps us to think in compression of or compromise of the nerve.
Great, very good. I think, oh, one more question popped up. Is hyperventilation test more important than MRI in diagnosis of vestibular paroxysms?
Had to be clear that MRI is not mandatory to do the diagnosis, but to do the differential diagnosis. You don't need the cross compression in the MRI to say that this is a vestibular paroxysmia, but you need an MRI to rule out other conditions. So if you had a positive hyperventilation and the clinical features and the MRI is normal, hyperventilation in this case is more important than MRI. You can say. But you need an MRI always.
Sorry, Sergio, how many I have yet to see a good vestibular paroxysmia, and so I'm not sure what I'm missing. I mean, maybe I'm diagnosing them as vestibular migraine and somehow, because we can't use the MRI for diagnosis. We see this vascular sort of touching in many people who don't have. So how do you diagnose? Is it based on the hyperventilation or?
Like in the old times of neurology, you can use a therapeutic proof. You can put the patient in carbamazepine, and this is part of the criteria for a probable vestibular paroxysmia. In my experience, the attack in vestibular migraine lasts always more than 1 minute. So it's difficult to confuse because the timing is completely different.
Sergio, excuse my ignorance if there is anything or strong literature on this, but I'm just wondering, can we use fMRI for these type of questions? What if we put these patients into the fMRI scanner and we show like a little area of hyperactivity in certain areas where blood vessels is near the brainstem? That can give us some idea, right? I mean, we do fMRI for neurosurgical cases all the time when we are doing mapping, right? So fMRI we can use in the clinical arena. It's not just the research.
I don't have experience with this, but I can tell you that there's some experience with 7 Tesla MRI against 1.5 and 3 Tesla MRI, and you don't improve the sensitivity. I don't know with the functional MRI, but with the big MRI, you don't have a better result.
One more question came up. I will call it a last question so that, okay, another one came up too. Okay, after these 2 questions, these are the last 2 questions. So first off, the last 2 questions come from Carolina Melan. If patient does not tolerate carbamazepine, what do you use?
Lacosamide. Lacosamide. This is new. There are some experience, especially from Dr. Strupp in Munich. So you can use lacosamide, which is better tolerated than carbamazepine. So
I also got that little enlightening from Michael Strupp, and I started using lacosamide for my patients as well, and I agree with you. It does miracles. It does it very well. The only issue in the United States with lacosamide is that it's very expensive, and most insurance companies don't like me if I order it, and they decline, and then we have to fight back. So that is something really needed. We need to go hard back on insurance companies to get lacosamide approved for it, but it does very well. And one other thing that I heard from Michael, I'm sure Sergio You may have better experience with that as well. I don't, because beta histine. So Michael, I was told that beta histine, when it is used with lacosamide, it does it very well for vestibular paroxysm. We don't have beta histine in the United States, so I don't have any experience with using that. But any thoughts on that?
Me neither. I don't have experience with beta histine in this condition.
Okay.
Talking about carbamazepine, that the doses that you need to control the condition are very low. Usually with 200, 400, you can reach a very good control of the disease. Yeah. So it's a dose that cannot produce word effects. No problem.
Okay. I've been using lacosamide in trigeminal neuralgia also, and it's quite useful there.
Yeah, yeah. The other question is, it's more of a comment / question. It's important to mention that the fast phase of nystagmus is in the direction of the site of lesion. Would you explain that phenomenon?
Well, I'm not sure about that. I cannot tell you that the nystagmus is always in the other side. In the case of the patient that I showed you, is right, but since it's excitatory condition, I'm not sure that it's always in the opposite direction of the lesion. Actually, it's not a lesion, it's a condition, you know?
Wonderful. It looks like we don't have any more questions. Thank you very much, Sergio. It is such a pleasure working with you organizing this. Thanks for doing the lectures. So our next speaker is Anirban Biswas. I think we are going to play a pre-recorded session.
Excuse me, yes, we had Miriam Huelgampola Ictal nystagmus in the program.
Is she later, or she's after this, right? You mean the next one is Miriam or next one is Anirban?
In the program is Miriam, but
oh, I think I have a different version of program. Sure, we can do that. So
I don't know if the technician has the presentation recorded. Otherwise, we can move.
Both of them is recorded, and none of them are here on panel. So I believe that either way. So I see Nicholas here. If Nicholas is interested in going first, then we can do Miriam and Anirban later, because both are recorded anyways. Would you like that, Nicholas? Would you
yes,
like to
give me 5 minutes, 2 minutes. Just I'm coming.
Absolutely. I mean, whichever way. We have other tools recorded, so we can go whichever sequence you prefer. We can. In meantime, let's say there is a question. When to send patients for surgical treatment, Sergio?
Vestibular paroxysmia?
Yes.
Vestibular paroxysmia? Never. No, never. You know, there was a big experience in the history of neurosurgery made by Peter Janetta in USA in the 80s. They operated many patients. The results are not good. Even in, I don't know, probably in trigeminal neuralgia, you need surgery, but not in this condition, not in my experience.
Yeah, a similar analogy, which is also more paroxysmal symptoms of nystagmus, downbeat nystagmus, commonly seen with certain kind of head angle position, and also quite analogous pathophysiology that vertebral artery is being episodically compressed because of the neck flexion and extension. And there was yet another surgical trial done in that, and again, the only thing that they could do is they could fixate the head, which is not very pleasant a lot of times for patients. So In any case, great, wonderful. It's such a pleasure. I'm sorry?
Nicholas is ready.
Yeah.
Hi, how are
I'm
you?
introducing